We have had a patient navigation system at the Cleveland Clinic for a while, and there's just rich data on what types of barriers the patients being navigated encounter. And we wanted to look at what these barriers were, and more specifically, we wanted to see what the effect of the Affordable Care Act was on these barriers, since one of the predominant barriers has been insurance coverage. So with the new insurance afforded by the Act, by the passing of the Act and the rollout of the Act, January of 2014, we wanted to know what the barrier profile of the patients, what that looked like post-ACA. While looking at these barriers, we had the option of looking at just individual barriers and seeing what the frequency of the barriers was and how it changed. But then we thought it a little more interesting to try to see what types of patients we were getting. A patient that presents with one type of barrier versus a patient that presents with many types of barriers and that needs patient navigation more frequently, for instance. Those are really two different types of patients. So we wanted to look at the data also at that level. It is particularly the underserved community. So it's communities that have lower economic resources, so lower socioeconomic status. Proportionately more minorities exist in those communities, especially in Cleveland, where we see a lot of disparities across the board. So Cleveland is a city with very high density of healthcare resources, and yet the disparities are widespread. So it's the responsibility, the ethical responsibility of healthcare centers, and especially one with, like the Cleveland Clinic, to really go out of its way and try to address these disparities by engaging communities that are our neighbors, basically, our neighborhood community that has lower socioeconomic status, are minorities, and as such have much greater barriers to care. Harold Freeman in the 90s really understood that the greater mortality rates in lower resource communities or the underserved really has to do with not being able to get timely and appropriate care for cancer, and that's all along the cancer continuum, from prevention and screening all the way to end-of-life care. So he came up with the concept of patient navigation, where individuals, they're actual human beings at the other end of the phone line, trying to address each patient's barriers. So they're financial barriers, such as insurance coverage, but also co-pays and then the cost of prescriptions. There's non-financial barriers, such as transportation, right? Being able to communicate in the language, so language barriers. Then psychosocial barriers, so for instance, just fear of cancer, wanting to just avoid, or cancer fatalism. Then there's also educational barriers. A lot of the community just doesn't know that early detection can have such a great impact on cancer outcomes. So those are the non-financial barriers. And then we have one that we call, and that we've coded for, as access, which really refers to the medical system complexity and the alienation that individuals can feel towards large and complex healthcare institutions. And then the comfort level when you walk into the institution and actually have to deal with the healthcare providers, all the way from nurses to the oncologists. Then the ability to get the appropriate appointments that work for you if you have a full-time job and you can't take off from work, or you need childcare. And then understanding also which appointments to make and what referrals do you need. So navigating all of that, and that's what we've encapsulated with the term access. We found that, as we thought, insurance was predominant before the Affordable Care Act. And then we see that after the Affordable Care Act, the insurance barrier has greatly gone down. But then what we see really come up is this access barrier. And not only the access barrier, but then the access-only barrier profile, meaning patients that really just required that extra push, that human at the other end of the line, someone to help them make the appointment and make them feel more confident and trusting to come in. And that's all they needed. But we found over 50% of the patients, and there was a doubling across the years. So from before the Affordable Care Act to now, where now they have insurance coverage, they're willing and able, but then the complexity and the intimidation of the large healthcare institution is still marginalizing to them. The take-home message is it's about connection and developing a relationship with the patients. And sometimes we get caught up in treatments and when we talk about disparities especially, and there's of course that's important, right? Getting the appropriate treatment and getting the patients through the office with the appropriate medications, and but if the physician can take a moment to actually figure out if there's a barrier that has to do with connection and with knowledge and about how to navigate the system. And sometimes it's just, feeling heard, right? That, I can pick up the phone and somebody is going to help me with my next appointment. That goes a long way. So taking a moment to understand the importance of connection, and then also that there are patient navigation systems that the patients can be referred to, where you have individuals that are dedicated to that full time. Socioeconomic disparities, as providers, we may feel that we can't do much about that specifically, but we can do a lot about this access barrier and this alienating factor.